life is a long journey, and there are going to be bad times. There are going to be, it doesn't mean it's cancer. It doesn't mean whether you make a mistake or, or something happens bad or, but there are going to be times where life is difficult. You're strong enough to get through this, and it will get better. You just have to you just have to tough it out, and you have to lean on people that you trust, and you'll come out on the other side a better person, a stronger person.
Hi, everyone. I'm Samira Daswani, the host of the podcast, The Patient from Hell. I have a very special guest, someone I think I would call a friend, and I have learned a lot from. We have done panels together in person, and now we have the privilege of recording something virtually. Hi, Rich.
Hello. How you been?
I've been good. Thank you for taking the time.
No, I'm honored. This is really cool. I mean, I love it. Just your title of your podcast is worth it. It kind of sums a lot of stuff.
I actually want to start with the poster behind you.
Oh,
what? Yeah, tell us that. What is it?
So it's kind of it's been kind of a motto of mine. Honestly, my brother-in-law had it on his wall, and I noticed it last Thanksgiving, and I'm like, you know what? I love that, because it's more of the life beats you up, but it's not how hard life hits you, blah blah blah. It's how hard you hit back and how hard you get up, because I don't know about you, but not just as a cancer survivor, but in trying to implement anything that you think is gonna be helpful, you lose a lot. You don't, you fail more than you win, and it's you can lick your wounds for a little bit and then suck it up, because as my grandmother used to say, like, really nobody cares. There's not, you need to move on, and and it doesn't do any good to sit there and wallow in your own self-pity. And I was like, you know what, I love that poster, and that's my poster. And then let's see if I can slide it. There's my other one that's on there. It's Bobby Orr. Back in 1972, they won the Stanley Cup. Actually, that was 70, I think. But and that's a famous photo of him flying through the air that he signed for me. Actually, it was at 29 years ago, wishing me luck and to raise money for my family.
Wow. Okay.
Yeah.
So you got diagnosed. Tell us what happened then. So you got diagnosed.
So I got diagnosed. Yeah, it was kind of a whirlwind. I married the love of my life, my college sweetheart, Pauline, and we got married in 1995 in August. August of 96, I was diagnosed with leukemia. So, my world just fell apart, and we were just, everything was going awesome, as most people's lives. You're moving along and you think you're going to be doing all these fun things and stuff, and then you're told pretty much, you had leukemia. I was actually at a patient's house performing care for this quadriplegic when I got paged by my primary care physician, who I had met for the first time earlier that day. And I got a conversation that was still surreal. Of I don't normally do this over the phone, but I talked to the hematologist, and your white count is blah blah blah. He said 395,000. So I said, I have leukemia, and he goes, yes. And he said, I told him you looked fine, but he's worried because there's so many cells, you could have a stroke. So I'm in the middle of care of this guy, can't leave. So I had to suck it up, finish this man's care because he needed it done, and I couldn't say a thing. It was all I could do not to cry, and finished my care and left and drove to the ER, where originally they thought I was in a very advanced phase, and all they could do was keep me comfortable. I got last rites and blah, blah, blah. But lo and behold, there was a treatment that you could do, and it was a allogeneic, a donor stem cell transplant. So I'm here 29 years later and lots of complications later, but I'm still, I'm still here and still enjoying life, and been very blessed with all of that. But
Right.
yeah, it was, at the time, it was the most devastating thing in the world. But I mean, you and I have talked before, but the post-traumatic growth of this whole experience has made my life better overall in so many ways. I can't even, count.
Give us the story where you end up in Dana-Farber as
So,
part of post-traumatic growth here.
okay, so yeah, you also have to be a little bit of a patient from hell, crazy, obsessed kind of person. And, you know, I, so I was a nurse at the time that I got diagnosed with leukemia. So I didn't really know a lot about, cancer because I wasn't directly an oncology nurse. And, but I educated, like you've talked to people about, I educated myself very quickly on like what's going on, learned all the stuff about it. And there wasn't very good treatment for it. So, I was at the Brigham and Women's in Dana-Farber at the Cancer Institute. And, basically, they told me that, they could keep me alive with these drugs, but eventually it's going to, it will kill me within about a year or two. And that didn't seem like a good option at 28. And, so they said there is another opportunity, and it's a donor transplant. And back then, I'm in the dark ages, if you will. Um, they said 4 people die as a result of the actual transplant. So the treatment, there was 1 in 4 people die because of the transplant, usually within like the first year of the transplant. But if it works, you can, you can live a long time. Because it is a cure in some instances. And this was before they had all these other drugs that like Gleevec and Sutent and all these things that are tyrosine kinase inhibitors that have changed the game. But back then it was do this or and die within or you get I can swing for the fences, if you will. And it was that was 1996 was kind of horrific because so I got diagnosed on August 2nd, I believe it was. My wife's brother had a grand mal seizure and died on August 20th. So and he was 30 years old. So and he had special needs, and that was why my wife was a special needs teacher. So my wife's dealing with a man who's she's married to, who's a basket case, and she just lost her brother who meant the world to her. And then they tell me, well, we can go get a transplant. So and so I had the transplant, and it was not, there were lots of issues with it. I had a lot of complications. But what I kind of, the physical stuff wasn't, it was difficult, but it was the emotional stuff that really I struggled with. But it was the doctors, the oncology nurses, the nurse practitioners, the physician assistants. I was amazed at the quality of care at the Dana-Farber and the Brigham and Women's, as far as like they were experts, which I had been a nurse for a while, and I didn't really consider most of the people I was working in home care, and I had done other things. I didn't see the expertise and the kind of like I'll call it a finely tuned machine, but also they were all emotionally aware of what was going on for me as a cancer patient survivor. And I kind of was, I was in awe of, like, I was like, oh my God, I couldn't have got through this without them. And I want to do this. So, I came out on the end, and I still don't know if I'm going to live or anything, but I'm like, it was, I told my wife, I said, I think they'll never hire me as an oncology nurse, even though I'm an RN, because, you just can't do that. So I had to figure out, how do I have to game the system? And I'm like, all right, I'll go back to school, become an NP, and then I'll get my I'll get my clinicals at Dana-Farber. And I did that, and that was another that was completely insane. I got into school, and the dean and the assistant dean just loved my story of, like, couldn't believe I'm doing this, and and I sacrificed a lot, and my wife sacrificed a lot. We had our oldest daughter now, but she was a baby. My special needs uncle lived with us, and I was working basically 3 part-time jobs while going to school full time because I was so passionate that I want to be part of what I was so amazed and grateful to them. I wanted to do this for other people because I wanted to give back because I felt like I owed them. But it gave my life a purpose that I don't think I had before that. I think it was more, I was very, I was very money driven, and I was very goal oriented towards, things and stuff. And, this really, helped focus a type A personality in the right direction.
I love it. Okay, so you go back, you get an NP,
Mhm.
you start working at Dana-Farber. I'm sort of skipping a couple of years here, but you then end up virtual prostate cancer clinic.
Yeah. So, I mean, definitely skipping a couple. It was, just to go back one thing, cause I think it's interesting. Because when I got, and as an NP school and everything, again, I was so passionate about it. I was not a good student in high school. I, barely got through and barely, was allowed to play hockey. But I ended up with the highest grade point average and everything else because I just loved this. I was like, I knew what I wanted. And I got to work with the head NP at Dana-Farber. I think they assigned me to her because they're like, all right, this is he's a little bit nuts, and she saw that I knew what I was doing and recommended me for a job. But it was interesting. She goes, I want to just tell you that um, there's a few nurses that aren't sure that it's appropriate because you were a patient, not at this in this. So that was like and not, I don't know, not, yeah, no, it was more of like, not sure if I could handle it, as far as like, the emotional impact and stuff like that. Cause it hurt, it hits so close to home. And that was probably, I don't cry very easily, but I was a little upset, but I realized like they were honestly thinking about like protecting me and worried about my interaction with patients and stuff like that. And I honestly, it was very hurtful, but it was understandable because I've seen like there are people that want to do what I did that should not be anywhere near patients. And and but that was pretty tough. That was kind of like a moment of like, and I just said, all right, I just have to prove I can do it. And I did, because the nurses that she told me, she was like, I just want you to know up front what you're dealing with. And but no, I became whatever, a fan favorite, if you will. But yeah, no, I worked in bone marrow transplant. I worked for my goal in life was to work for the physician that transplanted. And I did. And I was working for Joe Anton. And that was like, all right, I hit them, and then I moved into cancer survivorship. And then I got the opportunity to work with Dr. Paul Nguyen and Dr. Anthony D'Amico in radiation oncology here. And they're very important people in the prostate cancer world. And I had worked with them in survivorship stuff, and I got the opportunity to be an NP for them. And I was like, okay, I'd love to do that. And then after a little while, I saw like, I'm a very algorithm guy. I need to develop standards of like, this is how we function. This is how we do things. And I'm really good at kind of translating like what a standard is into algorithms for me. And, I saw prostate cancer and I thought like, okay, we have a problem. There's a huge pressure on the physicians. They need to see more new patients. There wasn't enough physicians. And, this is probably a theme you've heard on before, but there's not enough oncology providers to care for all these patients. And there's a lot of people coming in the front door, and, delays are, not just life threatening, but they're also emotionally toxic for all of us. And, so I said, hey, what if I think we could develop some software that could triage patients, and, we could do this virtually instead of them coming into Boston and spending 3 hours driving here. They could, we could do it remotely. We can manage them remotely because we're just managing their symptoms and their toxicities and are they relapse? We can do that remotely. And we weren't sure how well that would be received because, there's a, there's a strong love relationship between physicians and their patients, and particularly the patient who you've saved my life and I don't ever want to leave you. And, we weren't sure how receptive they'd be, but we surprisingly in our pilot study, 92% of patients were like, yeah, we'll do that. That's fine. Because they saw that the selling point was that I was integral part of the team, that they trusted me so I can trust you. Yeah, it turned into a huge success. We increased, follow-up, post-treatment follow-up. We reduced in-person follow-up by like a quarter and increased new patient consults for prostate cancer by 20-something%. And it was, it was remarkable, and it was great because then, when you look at the numbers, again, because everything's a business, new patients translate into new treatments, which translates into much more money than just follow-up care. It was, as one of the financial guys said, and one of the computer guys said, this is the first time that designing software has ever actually made money in healthcare that we can think of. We try to save money all the time, but this actually changing the work. So it was a very big, win-win because it was providing an option for patients that, wasn't there before. And this was 2015, 2016 that we started it, and then COVID hit and, I was the most popular guy, in the world.
Wow.
Yeah, it's been quite a ride. It's been interesting.
Rich, I'm gonna pivot us to a segment of the podcast, which is you wearing a combination of survivor hat and NP hat.
Mhm.
And we're gonna do 2 chapters. We're gonna do prostate cancer and then leukemia. And we're gonna dive into your favorite symptoms and side effects. And I want you to tell me what the symptom is or side effect. I'm gonna ask you to describe it or define it. And then I'm going to ask you what you recommend patients do to deal with.
Is this someone asking me?
Yeah, exactly. So this is a
Okay.
patient saying, I am grappling with Rich's favorite prostate cancer symptom.
Okay.
And what you tell them. Okay, we'll start with prostate cancer.
Okay.
So the first one, what are your top 3? Top 3 most common symptoms or side effects of a patient dealing with prostate cancer?
Top 3. So, okay. So I deal with a lot of patients who've had radiation, but they're all pretty much the same. Can you pee, poop, and get an erection? So, usually it's urinary issues. Usually it's bowel issues because of the radiation, and sexual function is something that, isn't discussed enough amongst guys and isn't quite, I think, I think providers do their best to try and explain it, up front. But just like I remember when you're discussing this up front, all you're remembering is like, okay, we're going to cure you. You're really not even listening to the side effect stuff. So it can be even like a surprise when they're, all of a sudden it's, but those are the biggest ones. But I can say that, the hormonal effects are pretty significant as well. But I think it's the long term after treatment is done and your testosterone's normal. It's the sexual function and the bowels and the urinary issues. And
Let's maybe start with the pee, then we'll go to the
peeing.
poop.
Yeah. So okay. So there's 2 things. So first of all, you have to know, does the person have a prostate still, or did they have their prostate removed? And because you can have radiation after you've had surgery, and that's a different way to care for people. But basically, so usually, so if you still have your prostate in, you could have 2 issues after radiation. You could have what we call obstructive symptoms. If you think of it like plumbing. Normally you have a 1-inch pipe that you're peeing out of, we'll say. Well, after radiation, that pipe could have a kink in it or a narrowing of it, and that makes it difficult to empty your bladder and it gives you like, it would manifest as like a weak stream, which would be getting up more because you pee, you think you're done, and then you've got more still there because it's trapped kind of behind this like narrowing or blocking. So typically we would use medications for that, like drugs like tamsulosin or uroxetrol, things like there's medications for it to help open it up a little bit more. You can even use things like daily Cialis is something that works as well. That can be a problem, but the radiation can also irritate the bladder and make it overly sensitive. So you have an overactive bladder, meaning that so you could have both things, but so you could have a bladder that feels like you have to go all the time, even though you don't, and you have a narrowing. But, so those are two things. If you have your prostate removed, you can have obstructive symptoms. That's less likely. That would be scar tissue. But you can have an overactive bladder and things like that. But so it's, we have standards that we will try and we'll try and manage these patients. And usually, that's part of what we did in the virtual care. We decided to develop, this is our standard way we're going to address these things so that we have, it's working with the patient because it's kind of a trial and error thing, as you've learned in medicine but yeah, that's kind of the urinary issues. And as well as the one thing after radiation, we always want to know if a man is urinating any blood. Usually that is because the radiation has damaged the bladder lining and the blood vessels are just a little bit on the surface of the bladder and they can weep blood. And typically, like if you're lifting something or, straining, it puts increased pelvic pressure, which can make the blood vessels weep a little bit more. And a lot of men with prostate cancer, because they're older, end up on an anticoagulant for cardiac reasons. So that makes it more likely you're going to bleed. So we always want to know that because it's not so much because of the radiation changes with the the blood vessels. It's because 5 years after radiation, there's a very low risk. It's about 1/3%. So 33, 1/3%. So 1 in 300, 100, 350 guys can develop a secondary cancer as a result of the radiation. One of the things I'm always asking, and we always ask in our standard surveys is, any blood in the urine. Mainly because we always want to, what I try to tell people is, I can almost guarantee you this is not cancer. It's a very low risk. Even, and a lot of guys will develop blood before 5 years out, but it's still, what I tell them is, because bladder cancer is a bad thing if we leave it go, we always want to investigate first and rule it out. Even though I don't think it's that, I always try to preface that I don't think it. I don't want to scare them, but I say I would also not feel comfortable if I just let you go and assumed it was, and so we always want to know because men can have a bladder cancer as a result of radiation, and usually it's very easy to treat because it's a very superficial and can be done with just surgery, but that's something we always want to know, as well as if they're having any blood in the stool, a similar type thing where blood vessels can become more prominent in the rectal area, but there's also a risk for a rectal cancer.
Got it.
For that,
would you tell men
yeah.
with, I'm going to move to erection.
Yeah, go ahead, yeah.
Would you tell men who are dealing with sexual dysfunction?
The first thing I do is I acknowledge that they are, and that it is a significant loss they have, meaning, that they're right. We did this to you, and it was a necessary evil, but it forever changes you of how you think of yourself as not just a man, but as a human being. We're sexual beings, and my daughters would cringe if they heard me saying that, but I mean, it is part of our life, and we forever change it. We never make anything better, other than curing you of cancer. The rest of it, we don't make it better. We don't make it, although I shouldn't say that. We sometimes do make the urination better because some guys have such horrible urination going in. but usually we make things worse, and definitely with sexual function, it is going to impact it. Usually, um, so usually the good thing is most men, if they have a prostate in, most men will respond to medications like Viagra and Cialis, that class of medicine. So usually that's very effective. And, I used to be most well known for, being the guy that could get them cheap Viagra, because back in the day, Viagra was so expensive, and I actually, and again, I get a little crazy, but I get very passionate about like survivorship stuff, and like these guys, like through no fault of their own, need Viagra and Cialis, and it was very expensive back in the day, and so I my local pharmacist, literally on the same block that I lived, I talked to him. I'm like, look, what 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 does it cost, at wholesale? Could I start writing scripts here and we sell it above wholesale for what you're comfortable with? So we would get them. And now it's very common that you can do that. They've got, even CVS's with Good RX and stuff like that. You can use coupon. But this is a while ago where I'm writing to Brown's Pharmacy in Winthrop, Massachusetts. I'm writing scripts for like tons and tons of guys, and they're filling like, whatever. We'll say it was like $25 for 90 pills. They would fill it for 30, and where they would be paying crazy money if they didn't. And, it was just a way to figure out how to help someone, help them that, that someone would do. But now you've got a lot of options. But yeah, that was like, everyone, like I'd have doctors like, how do you do this? How do you I'm like, just send them to me. I'll do it. But yeah, but it was kind of trying to solve a problem. But so guys, usually we try, Viagra, Cialis, and usually we want to try like the maximum dose of those drugs to see if it works and if they tolerate it, because it can have side effects too, with that are bothersome, like stuffy nose and, other issues. But, and then if not, then we want to refer to usually a urologist, but a men's health specialist to talk about other options like penile injection therapy, which is a very effective um, method to use for erections, but it is not exactly the most appealing thing to put a needle in your penis. So it's a little tough to get them to kind of, but they come around after time, sometimes. But and that's that, but uh, it's really devastating for these guys because they'll never be the same. So some guys are like, they're not as sexuality wasn't as big a thing for them maybe as they got older, but other guys are completely devastated, and they have 100%. And that the whole thing is to be honest with them and be like, yes, we did this, and you have every right to. And I'll say, to grieve for this. You have lost this sexuality, what you knew it was. And thankfully we also are lucky enough to have Dr. Sharon Bober. She is a sexual health specialist. She's a psychologist. Has a sexual health practice at Dana-Farber that we can refer to talk about the emotional impact of that. Also about ways to improve libido that aren't just about erections and things and so it's kind of letting them know that they have every right to feel the way they do, and that it's not wrong to complain, or it's not wrong to bring that up, like because that would be the worst thing to do to a patient, is to kind of like poo-poo them, or like oh, you should be grateful that you're alive, kind of thing, which and that's why people tend to enjoy working with me, at least in those aspects of things, because I try to understand, I mean, trust me, there's some patients that, are really the patients from hell, but, but they usually tend to be mine because I understand where most of them are coming from. You know what I mean? I understand why they feel the way they do. And probably the saddest thing for me is when like, can't, I can't help them emotionally. that's always been the most devastating thing for me is, I can't get them out of, this cycle of their thinking that is making their quality of life horrible. But it's because of, certain, things where, but that to me is the, toughest part. Cause I remember feeling that way, and I remember getting caught in that loop of, just devastating thoughts and, thinking about your mortality and thinking like, and not being able, and getting stuck in that loop, that, thought loop that is just, just destroys you, and, so I don't ever want to like, I don't ever want to not acknowledge it, but I also, I think surprise them because I do say, I do have to, I do confront them about it too, where it's, look, I understand where you're coming from, but it's not serving you any good because if we have to figure out how can we get you to, you know, not accept it, but figure out how we can get you to a better place than you are, because this constant doing the same thing is not going to work for you. And it's just making your quality of life better. And I've heard you say before, like quantity of life is awesome. And I used to put these slides up all the time that quantity of life, we want you to have the longest you can. But if your quality of life during that quantity is horrible, then that's torture, and that's not what we want. That's why like it's great to see so many studies are going on about, okay, how do we improve the quality of life of people, not just after treatment, but while they're going through treatment, and looking at, because that's the name of the whole game. It's life that, is you want to have a good quality of life, regardless if you had cancer or not. But cancer just makes it harder to have a good quality of life.
Rich, so I'm gonna use that as a entry point into our last segment, about rebuilding life post a diagnosis. I think I've heard you say post-traumatic growth. You described kind of on the professional side. You married your high school sweetheart,
Yep.
if I understand correctly.
College, but yeah. No,
College
my high
sweetheart.
school sweetheart dumped me, but
Well, I'm
that's all
sorry.
right. I upgraded.
There we go. Yeah, exactly.
I married up. Trust me.
What kind of how did your relationship change post diagnosis, treatment? Tell us about that. Tell us about what kind of advice you would give your daughters and how to live their life.
um,
And then my last question for you as kind of the wrap up is going to be what advice you would give to someone who is transitioning out of like active treatment into this like new chapter, long tail
sure.
survivorship, as to how they can rebuild their life.
Okay. How did it affect our relationship? So my wife is a trained special ed teacher. Dealing with me, she was equipped to deal with me. I would have been one of her students in when I was a kid and through high school, but as an adult, she was able to deal with kind of the emotional roller coaster that I was going through and everything. And thankfully, I had this awesome psychiatrist that really helped me process everything. But and I was 28, so I was in the AYA group, and so it was, and we hadn't had kids yet, so that was so that was probably the biggest thing for us was the it was about less than wasn't even a year, I think, out of my transplant. And so there's a backstory. So basically, before my transplant, about a month before my transplant, I was getting, so my wife and I, we didn't tell anyone, but found out she was pregnant about, it was September of that year, 96. So we didn't want to tell anyone until we knew more. And then, in, late October, beginning of November, I was on a pheresis machine getting my blood collected, because back then they would collect your blood in case your graft failed, meaning the donor's cells didn't take. They give me back the leukemic cells to keep me alive. But so I'm on a machine, and my wife started spotting and miscarried while I'm useless to her. So my wife is the toughest human being you've ever met. And, so she lost the child that, we didn't really even tell anyone about. So this devastated her. And so I had my transplant a month later. She doesn't know if I'm going to die. And my godchild, my niece, was born basically a month after basically while I was in the transplant. She was born, which was awesome for the family, but that was tough on my wife too. She loves her niece and all that, but you know what I mean? It was tough and I'm a self-absorbed guy who's just trying to stay alive. So I was just like so unaware of the impact of any of this. And, and it was, I want to say August of 97. And she was like, I want to try and have, a baby. And I'm like, my first thought was, are you, shitting me? Because I'm like, in, a month, I'm not even sure what, like I'm doing pretty well. I mean, but I wasn't working. I was still, and then, and then we talked about it and and I thought about it and I'm like, she deserves that, I mean, cause thank God my social worker before my transplant talked me into having banking sperm. Cause when she kept she was very persistent. Thank God Mary Lou did, because, I was just like, I don't care if I have kids. I just want to live. I don't care. I don't care. I don't care. And, and my wife wasn't pushing it or anything like that. But Mary Lou, I finally was like, all right, I will. I left one sample and, thank God we did. But, so in August, I'm like, okay. And I'm going to be frank with you. I basically said, well, what's the worst thing that happens? If I'm dead, I'm not going to know about it anyways. And she's going to raise the child. So I don't have to worry about it. But I was like, that's how my brain worked. And, so we're like, all right, let's try this. And, so then, which my wife to this day is still pissed about, the guy, and I understand why this guy did it too. He's the head of the, of the fertility at the Brigham in, Dana-Farber. And he's, I'm 6 months out of a transplant that they don't know if I'm going to live or not. We go there and we're like, yeah, we want to have a kid. And so he made us write a letter, of why we should be allowed to have a kid, which was, yeah. Oh yeah. And my wife was out of her. Yeah. So needless to say, we had 2 children, my daughter, Crystal. So we did in vitro. And at the time it was experimental. We did ICSI. Crystal was born. We froze away some embryos. The second cycle didn't work. We froze some embryos, and the third cycle, and then we implanted the frozen embryos, and Shayla was our, frozen embryo, our youngest daughter. And, thank God we had them. But I think, my wife and I are, what doesn't kill you makes you stronger. And that's not for everyone, because I mean, I statistically, I want to say it's like 50% of, marriages end in divorce after, cancer. And, it was not easy. It was, I mean, the thing that, the other thing you don't hear is, okay, not this, the fertility thing was horrible. And it gave me an understanding of the impact on female survivors that I was, ignorant to as a man. And, it, it made me understand, it helped me understand that better. But my wife and I just realized, like, you can't sweat the small stuff. The other things I'm sure you've talked about before with people is it's financial devastation, particularly when you're younger. And, I'm a big breadwinner for the family and I'm not working. And, we lost, pretty much our, other than our house, we lost the real, our rental properties that we had. And because, again, and I'm not crying or anything. I'm just saying it is devastating and it's hard to recover from, and it takes years. It brought us stronger. It brought us closer, I mean, and like I said, she's the most patient human being in the world, because, I am, I'm not easy to deal with. And I know that, in a lot of ways, but, and someone coming out of treatment into survivorship, I think for me, I think the best advice is develop a roadmap for yourself. And and this isn't to plug anything one or another, but I mean, you need to kind of like there's guidelines and there's all kinds of crap out there, but the problem is it's out there and not everyone has time to figure out what that means or to translate what that means. And it's a lot easier to it takes away the fear of the unknown because that's one of the worst things as a survivor. Because I remember when I was in the hospital and they told me, okay, you can go home now and you can figure out, you'll come in so often, but you'll let us know if you're not feeling. I'm like, no, 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 no. I'd rather just stay here because you know what you're doing and I don't really know. And that fear of what could happen and the unknown because you're so used to doing something like actively fighting it, and then all of a sudden you're like, all right, we're going to stop and we're gonna wait and see if it comes back. That's a switch in mindset that's very difficult, and I think um, getting a roadmap, finding whether it's through technology, it's doing your own. I mean, what you did for your journey, and people should really look you up more about how you did it, and that's ideal because I think I told you I wrote like my I wrote a little like entry book called Safe Journey of like what I think you need to do. And it's kind of like just mapping out like what do you need to know? How often am I followed up? What do I need to worry about? And when should I call you and things like that? Like, so it I'm a very algorithmic guy, but it's really I want to know what's going to happen in advance. And that's what patients appreciate about me is they're like, they'll always ask, well, what if? And I say, all right, well, I'm going to tell you possibilities, but that helps people to process like, oh, all right, well, that's right. I can look here and it says, all right, my next visit's this. If the PSA gets to this, and that's what it is. It's, um, what you need to do is force the oncology people to translate what they know in their head so that you can understand it and you can know what to expect because that takes away a lot of the anxiety and the fear of this and it makes it more understandable because nobody can be an expert in all this stuff and nobody especially when you have a whole life you have to deal with yourself. I mean, you need to make it so it's easily understandable and it's something you can refer to. And, ideally, it would be somewhere that you could find out what's your roadmap of what to expect, year by year kind of thing. And then, okay, if I have these issues, could I get more information based on that? That would be my ideal. That's kind of like where that if I had, $1 billion and, I could do that. That would be what I'd do is I'd design roadmaps for people on cancer journeys and then link it to good information on how to manage it if you have it. Because that for me is the holy grail because it also unburdens, the provider because not that I mind, but I'd like to not regurgitate the same information to, you know, people over and over again. Like my daughters can, like, because my daughters hear me all the time. They'll tell you about like how to manage erections and how to do because they hear me say the same stuff over and over again. But that's what I mean is like it's all for me. It's easy because I do this all the time. It's in my head and I know what I'm doing. But there should be a way you could download a video that explains like what you could do, how you could ask, could I get a prescription for Viagra, whatever, you know what I mean? And that's just one example, but patient education linked to a roadmap is kind of what
I
I would
super
say.
appreciate the unsolicited plug to the Manta platform.
Yeah, no, because like I told you, I said, you're doing what that's what I want is like, because that's the patient part of this, and then it's addressing like a lot of the provider stuff on the other side, but linking all that up so that it's one thing and it's, and it's communicate. Yeah. But, that's kind of where it's not that hard. But it's hard because it's not what's being done. And that, and it's, you just have to keep banging your head against the wall and, eventually, it'll happen, and then it's nice to see like, I'm 58. you're younger and you're doing this and you're making, and that's what I mean is it's exciting to see because finally something that really makes sense versus, just republishing the same foolish things again, over and over again. Pardon my French.
I appreciate it. Here's my last question for you. You ready?
Yeah.
Last question.
Yeah.
Think short summary. What is one piece of advice you would give to your daughters to live a better life?
Life is, a long journey, and there are going to be bad times. There are going to be, it doesn't mean it's cancer, it doesn't mean but you're gonna, whether you make a mistake or something happens bad, or but there are going to be times where life is difficult, and and that you're strong enough to get through this, and you have people in your life that love you and are there if you need them. But that life does get better because it can seem very dark at times, and but it will get better. You just have to tough it out, and you have to lean on people that you trust, and you'll come out on the other side a better person, a stronger person, and that'll just be one more piece of armor that you can wear. But that it's being, and not that I think about Rocky all the time, but it really is. Life is about, because the best things that have come from my life is when either something bad has happened to me or I failed, and I realized, like, okay, as they, what's the other, every door that closes, another one opens, kind of thing. But that life isn't going to end in that instance. You just need to kind of persevere a little while, and it will get better. And usually it leads to bigger and better things. It's just that you can't see it at that time. And that would be life. And that would be Rich Voyaging. If you're listening to this, that's my advice to you too, because I need to remember that too, because, it isn't easy to, it's sometimes hard in the moment to see these things. But, I think that life is, it's a long journey made up of, lots of interactions, lots of, things, and that, you're going to experience great things along the way, and you're going to experience sad things. And that's life. You don't want to live in a simulation where everything's wonderful. That's not life.
Rich, thank you so much for coming on the show. I appreciate
Anytime, young lady. And
thank you.
Anything you need, you let me know.
I will for sure.
All right. Bye now.
This podcast, show notes, and newsletter is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice, and no doctor-patient relationship is formed. The use of information on this podcast or any materials linked from this blog is at the user's own risk. The opinions of the speakers are their own and do not represent the opinions of organizations they're affiliated with, nor do they reflect the opinions of Mantacares Inc. or Mantacares' sponsors.